Top Med Talk.
Welcome back. I'm Monty Mythen, coming to you live from the Top Med Talk studios in West London, here for day 2 of the EBPOM 2021 World Congress, our 24th year of attempting to bring the community around the world together to discuss perioperative medicine issues. So, really delighted to be chairing this session. I think I was chosen because I know almost nothing about it, but I do have a few opinions about trial designs. It's about cancer and anaesthetic drugs. It's been lingering along for quite a while now, informed by the basic science, informed by the preclinical work, and informed by observational studies, to suggest the fact that the way that we provide anaesthesia in the broadest sense should have an impact on cancer outcomes. Got a fantastic panel from Ireland, Canada, the UK, Australia, with a hint of South Africa that we'll come back to, and the United States of America. So I'm going to go to our first guest from Ireland/Canada, which we'll explain in a moment. That's Tom Wall. Tom, it says on the can there that you're an anesthesiology fellow from Vancouver General Hospital in Canada, but I think we just discussed in our sneaky pre-chat that that's not exactly where you are at the moment.
No, thankfully I've escaped from the extreme oppressive heat of Vancouver for a few months now, and I'm back in Dublin. I'm currently an anesthesiology consultant and in the Mater Hospital. I'm a member of Donald Buggy's Onco-Anesthesia Research Group, and I also have an academic affiliation with University College Dublin. So I've worked with Donald over the past few years, a lot of his onco-anesthesia work.
Now, Professor Donald Buggy is extremely well known around the world, but also well known to us at EBPOM for a number of different reasons, because our original evidence-based perioperative medicine meeting is held in Ireland, in Dingle. Donald's been a very regular visitor there and a major contributor to EBPOM over the decades now. And a recurring theme has been Donald discussing a trial to specifically address one issue that relates to the provision of anaesthesia and outcomes from surgery, and in particular cancer surgery. Now, Tom, I know he's put you up. He's done the pre-record for us, but he's put you up to answer a few questions for us. Or perhaps just give us an outline of the trial design and give us the result, because I'm going to suggest for this session that there's overall, I think we've got equipoise, but we do have at least one result. Tom, what trial are we discussing? What was the outline and what was the result?
The trial was a very large randomized controlled trial that was led by Donald and Dan Sessler in Cleveland, multi-center study run in predominantly the US, Ireland and China. Running over many years, these trials are difficult to and long to actually enroll patients to. So it involved randomizing patients undergoing breast cancer surgery to a anesthetic technique composed of a paravertebral block and largely propofol-based anesthesia versus a volatile and opioid-based anesthetic technique. So that is two components of one technique, which have under laboratory and preclinical studies supposedly or putatively protective benefits against cancer recurrence, that is propofol and regional anesthesia, versus two components which have some evidence from preclinical studies that they have potentially harmful effects, that is opioids and volatile anesthesia. So it was a large study that enrolled well over 1,000 patients, and they stopped recruiting after the first interim analysis across a futility boundary showing no difference in recurrence rates between the two arms. There's roughly a recurrence rate of 10% in each arm. Also showed there's no difference in chronic pain incidence post-operatively in these patients. So this is the first large randomized controlled trial examining the effect of regional anesthesia on cancer recurrence. And it had essentially a negative result. It's the first very high quality result that we've had from trials on anesthesia and cancer recurrence to date.
Tom, some lessons from this. One is, the importance of people having equipoise and the willingness to recruit to these studies, because when Donald was presenting over, I think it was decades in the end, certainly over very many years, one of the challenges was getting people to recruit patients to the trial because of lack of equipoise. And by equipoise, we mean the willingness to accept that we don't know the answer, to believe in certain things, like, for example, the block must help, and therefore not be willing to randomize. But it turned out, despite the observational data and the preclinical data and the science, that the answer was no difference.
Much of the evidence that had been accumulated, particularly the laboratory studies, virtually every molecular mechanism and molecular target that could support a potentially beneficial effect of propofol or local anesthetics has been shown under laboratory conditions in vivo animal studies that it could have potentially beneficial effects. But we had very little evidence clinically. There were some small or a lot of small retrospective clinical studies, some of which showed potentially beneficial effects, some of which showed potentially harmful effects, and meta-analysis were largely conflicting. But certainly the laboratory evidence would suggest that there would be beneficial effects. But certainly in terms of clinical equipoise, that did exist at the start of the trial. But you're right, a lot of people were under the impression that propofol and regional anaesthesia would provide a lot of benefit, but that was not borne out in the trial.
But this is the beginning of a journey, not the end of a journey, which is going to prompt me, if I may, Tom, to bring in our next guest, Joyce Yeung. It says that you're an Associate Clinical Professor of Anesthesia and Critical Care from the University of Warwick in the United Kingdom. But you've recently been appointed to a new role, which is in your presentation. But if you could just share that with us, Joyce, and congratulations, by the way. I know I tweeted congratulations, but it's great to congratulate you in person.
Thank you. That's so kind. Yes, I was lucky enough to be appointed as the Director of UK Perioperative Medicine Clinical Trials Network. So I've taken over from Professor Rupert Pearce and inherited a great network of enthusiastic researchers. So very exciting.
I was lucky enough to be part of the setup of the POM CTN at the beginning. So I know intimately what a wonderful job Rupert did with the whole bunch of collaborators to set you up. Thank you for taking on this challenge under difficult times, but difficult times always also present great opportunities. Now, to dive into this subject, Joyce, in your presentation, you told us about I think it's called the VITAL trial, which is in the pipeline.
Correct, yes. Actually, interestingly, VITAL study was a research question that the members of POM CTN, if I call the network by its short name, has voted to be one of the top 3 research questions that is most relevant to our members. And we also feel is a very important research questions to patients. So the VITAL trial is a randomized control trial where we're going to compare volatile-based anesthesia with intravenous-based anesthesia to see whether there will be any patient benefit in terms of outcomes from major non-cardiac surgery. It came through a SAMPIT research day, so the research question actually changed quite a bit from sort of a much more focused on particular outcomes to now maybe slightly broad outcomes that's more applicable to more patients. And we've been lucky to have been selected to be funded by NIHR HTA themes. We should be starting any time now, this year, 2021.
So Joyce, congratulations. But on behalf of the broader, less trial-orientated community, I thought Tom just told us that we knew the answer to that question.
Oh, yes. I think there's still quite a bit of ongoing debate. I think at the time when we applied for research, we knew that there were research ongoing and we may have more results when we're going through the design process. I think the reason why the members voted for this research question and why we still wanted to have a funded study to look at this question is that some of the outcomes we've traditionally looked at, such as mortality and maybe length of stay, data that's relatively easy to collect from hospital records, still lack some of the details on what really matters to our patients. So the focus of the VITAL study is on patient recovery. So we spoke to our patients and they say that for a successful surgery, they want to be obviously survive the surgery, but they also want to recover really well and be able to go home very well. And although that if you speak to anaesthetists, as you know, they will have their personal preference and they will believe that their type of anesthesia may have benefits over other type of anesthesia. But at the end of the day, we just don't know. We've never compared these two types of anesthesia head-to-head in a randomized controlled trial setting, where we're focused more on patient recovery rather than just survival benefits. So I still think that there is a lot of questions to be answered, and we demonstrated that by being able to recruit interested investigators, and we're hoping to contribute to the ongoing debate.
So unlike the trial that Tom was referring to, which specifically related to cancer and cancer recurrence, which was the primary question that they were trying to answer there, I think you're telling me this is specifically not a cancer trial. It's a very fundamental question. Does providing anaesthesia with intravenous drugs without the vapours, if you see what I mean, have a different outcome to traditional, which was a sort of vapour-based anaesthesia? It's as fundamental as that.
Yes, absolutely. We have chosen not to just focus on cancer patients because I think that they are, although cancer resections is a large proportion of our work, there are also other types of surgery and patients coming in different types of surgery at the same time. And we know that people are starting to change their practice, maybe moving away from volatile because of potential benefits for cancer patients and also for environmental concerns. But before we all switch over to intravenous anesthesia, perhaps we should ask ourselves, do we know enough about the techniques to say that we are doing the best for our patients? And I think Vital fundamentally answers that question.
I'm going to be a bit of a clinical trialist now. Your primary outcome variable is?
Days alive at home by 30 days.
Also slang DAR 30, is that right?
That's correct. I call it DAH 30, but yeah, or
okay.
DOAH 30, yes.
Well, we'll settle on that. But the idea is the number of days you're home and happy added up. So if you, for example, had a 5-day length of stay, went home and were readmitted 5 times for 1 day, then you adjust that to say that you've had 20 days at home and happy type of thing. So it's quite a clever outcome variable.
Definitely. The outcome lets us measure how quickly patients are able to go home. Also, if they've had a complication or an unexpected event that they need to stay in the hospital, we will capture that. Or if they went home and then subsequently had a complication which meant that they need to come back into hospital, we can also capture that. So in many ways, it gives us a lot more detail on how patients recover and whether they're able to go back home or the home environment where they want to recover from the surgery.
So Joyce, there's a lot more information in your pre-recorded lecture. You also touch on some of the environmental issues that are not as clear-cut as it's all the vapours are bad because they're gases and that's hurting the planet. There's the propofol plastic question, etc. as well. But you also deal in your presentation about the efficient trial design leaning on something called P-QIP, which we heard a little bit about from Professor Ramani Munasinghe. Could you expand on that bit of it a little bit? It sounds like you're cheating.
I hope it doesn't sound like we're cheating. We certainly went for a funding stream by NIHR, which looks at ambitious data-enabled trials. I'm glad that most of the people who are joining us today will know a little bit about P-QIP already, which is a fantastic program that's been going on for a few years, led by Professor Munasinghe, collecting outcome data from patients after a major non-cardiac surgery. And we know that they have well over 32,000 patients on their program already. And we thought they've got a brilliant database set up. They've got all these sites engaged and already following patients up from major non-cardiac surgery. Why do we not design a trial that we can harness that power so that we can work with sites already knowing how the database works by adding in additional fields that are suitable for vital study? We should be able to set sites up much quicker and limit the burden that we potentially put onto site teams and patients, because we can say that you will be completing questionnaires based on the P-QIP study you're participating in, but we'll also use your answers and some additional answers to answer another fundamental research question. So we are taking a step to take on a slightly different trial designs. Although we are doing a randomized control trial, we're trying to be innovative and trying to be efficient, especially in a time of COVID. I think everyone just wants things to be a little bit simpler if possible.
Joyce, I'm going to close this direct me and you section by asking you about your primary outcome variable, the power calculation and the sample size that you're trying to recruit. Is it event-driven or is it you're going for a particular recruitment threshold of patients?
When we spoke to our patients, listened to them, and we discussed what would be sort of the threshold where we should persuade clinicians to change our practice and what difference should we be looking for. So what is meaningful to them? And it might sound simple when we explained it at the end. We're looking for absolute difference of 1 day between the two techniques. Now, you would say 1 day out of 30 sounds really small, but actually when you speak to the patients and the family, even if it's just 1 day, which will translate to a weekend when it's 90 days, or even more days if you lengthen the time, it does make a difference to patients because freeing up 1 day means the patient can go home quicker. But freeing up 1 day will also mean the next patient can come into hospital that much quicker. Even that small difference will drive a patient benefit, cost benefit, and a service benefit that's enough for us to consider changing our practice. So the sample size of 2,500 patients is based on that calculation.
2,500 is based on that. Got you. Thank you.
Yeah.
Tom, comment or question for Joyce?
Yes, thank you, Joyce. It sounds like a very interesting trial. I was wondering, just from the onco-anesthesia perspective, I know you're not involving, not all of the patients will be cancer patients, but I presume a lot of them will be. Will you be following them to gather information on longer-term oncological outcomes, such as disease-free recurrence or overall survival over 5 years or so, because that would be a very interesting and useful addition to the evidence base.
And something that we thought long and hard about. At the moment, the VITAL study is funded to follow patients up for 6 months after surgery. But that does not stop us from looking at ways of trying to link up with longer-term follow-ups, maybe with cancer registries. And also, although we haven't specifically just focused on cancer patients, we have planned some subgroup analysis that will look at whether there's a difference, sort of a short-term outcome, which is only up to 6 months, between cancer and non-cancer patients. And I think that, although it's not powered to do so, it will still help us generate the next research question and perhaps design the next study that may focus on this group if we find a signal or something that's suggested.
We can now bring in our next guest, which is Professor Bernhard Riedel. If we could get Bernhard up. But Bernhard, great to see you, my friend. I put in my introductory thing that we were going to go to Australia and a little bit of South Africa. So you're at the University of Melbourne, Australia. You're actually at the Peter MacCallum Cancer Centre, as I remember. Is that correct, Bernhard?
That's correct, yeah. So it's Australia's only sort of public cancer centre dedicated to cancer and affiliated with the University of Melbourne.
But you're a global citizen. I think you started off in South Africa. Is the people think getting a hint of an accent there? And I think you've
probably
done sort of
even further north than that, Monty. I was born in what was southern Rhodesia, turned into Zimbabwe.
Yeah.
Medical training in South Africa. Worked in London for 5 years in the cardiac unit there. 10 years in the US. Got to know Vijaya quite well, who will be joining us on the panel.
Yes.
But I worked at MD Anderson Cancer Centre. And I've been here at Peter Mac for 10 years now.
So quite a journey. I'm not going to ask you what your favourite place is. We're going to assume it's Australia at the moment. Now, Bernhard, have you heard of this COVID thing that the rest of the world's got?
On travel, we are totally locked down and we'll be locked down for another 3-4 years. I don't see Australia releasing the borders. Okay. So, but that's not for me to speculate. That's for our government officials. But true, we've come through it relatively well, but we got to exit somehow.
We were talking to Paul Miles a little bit earlier, one of our Pokapalooza conversations for our world sort of reflection. And that understandably presents an opportunity with a natural experiment for us, for Joyce, for example, and Tom to compare some of their outcomes in the COVID-rich world, terrible way to refer to it, but there's a lot of long COVID in the UK, for example, to your patients who have probably not been exposed to COVID much yet.
True. No, I think the chronic disease burden associated with COVID that we'll see in the periop phase will give some interesting comparative data.
And you're going to talk to us about another trial that looks at the type of anaesthetic and outcomes, and particularly this time, I think, again, it's cancer outcomes.
The study is called VAPOR-C, so volatile anesthesia and perioperative outcomes related to cancer. That's what the acronym stands for. It's designed as a 2x2 factorial design. So we're going to randomize patients to volatile-based anesthesia or to total venous anesthesia with propofol. And then it's a sub-randomization to lidocaine infusions or placebo. We're trying to address 2 questions within that cohort. Does propofol Tiva have a better outcome in terms of cancer, or does the lidocaine contribute to better cancer outcomes? So the primary endpoint is disease-free survival. It's a event-driven study. It's going to be cumulative recruitment until we have about 957 events. So that's what it's powered to. And so we estimate we need about 5,700 patients. And that was pre-COVID. And recruitment it's been slow. And hopefully post-COVID we'll be able to escalate the recruitment rate.
And or peri-COVID, because I think we're all now trying to get through our backlog of cancer surgeries in particular. But as part of that, we've been trying to have this message to say, I know we're trying to get on with things in a cost-constrained environment, but it's really, really important we try to recruit as many patients to trials as possible. This is an opportunity to try and maximize our trial recruitment. No better, and we saw that in COVID, no better time to answer some of these questions. The lidocaine or lignocaine, is that infiltrated or is that intravenous lignocaine? Because we know the prior version of it, that the IV lidocaine as a form of analgesic or anti-inflammatory has been around for a long time, but it's become much more fashionable.
It's intravenous lidocaine. It's a bolus of 1.5 milligrams per kilogram, and then an infusion that runs at 2 milligrams per kilogram per hour. It's dosed according to adjusted body weight, just for a bit of safety precaution. And it runs out to a maximum of 4 hours, at which time we then reduce to 1.5 milligrams per kilo per hour for the duration of surgery. And the intention is to cover that peri-op phase or the intra-op phase.
You covered off in your presentation very nicely the biology behind that, the pharmacology behind that. Why should that make a difference to cancer?
So lignocaine's got interesting properties. It seems to preserve some of the immune cells. It may be indirectly through anti-inflammatory process, but it is a SERC kinase inhibitor as well. It seems to demethylate some tumor cell lines, but that's in vitro studies. What we're also seeing with lidocaine, and Donald Buggy did some elegant mouse studies where he resected a breast cancer xenograft model under sevoflurane or sevoflurane plus a lignocaine infusion, and then harvested the lungs and essentially showed on a logarithmic scale that there was significantly greater incidence of metastatic lung disease in his mouse model. And so I think it warrants exploring the use of lignocaine in the cancer setting. And as you say, it's become relatively widely used, especially in an ERAS setting, in colorectal surgery. We need to understand whether it's got protective properties or not.
I just want you to focus for a second on the fact that you said it was event-driven. So that sounds smart to me. So as opposed to choosing the size of the population, you said your primary outcome variable is this, and you're going to accumulate that number of events, I think, and then have a look. Is that correct?
Correct. Yeah, so what we did is we estimated based on what we anticipated were the stages of disease we'd recruit, and looked at their recurrence rates. And then we're also recruiting colon, rectal cancer, and lung cancer, just to show across different cancer types. So within those disease profiles, what their anticipated recurrence rates are, based on staging and histology, etc., and then extrapolated to expected number of events.
Bernhard, do you have any questions or comments for Joyce first and then for Tom? And then we'll turn the guns back on you for a moment in the friendliest possible way.
Yeah, the comments I have, it's exciting to see Joyce working on vitals. I think we've got a common endpoint as well, so which will make it very interesting and able to combine our studies. So we've built in 30 days or days alive at home 30 as a secondary endpoint, one of our main secondary endpoints. And the reason we find that endpoint important is because that often determines whether your patients go on and have adjuvant therapy or not. Frailty and complications after surgery are probably one of the key drivers of failure to have adjuvant therapy, or the acronym for that is RIOT, the return to intended oncologic therapy. And so understanding how we can impact and improve recovery in the immediate postoperative period is important in the cancer patient. If not more important than the actual anesthetic technique is making sure our patients recover, have their adjuvant therapy, complete the cancer journey. So from that point of view, Joyce, extremely excited that we can collaborate, we can share data, etc.
Joyce?
Yeah, absolutely. We're hoping that by combining what we find from our study and Bernhard's fantastic Valuebased study, and maybe an upcoming American study, will amount a critical mass in trying to answer this research question, whether our anesthetic techniques offer any benefit to patients when they recover from surgery. So absolutely excited. Great to see what Valuebased will be doing as well.
Bernhard, for Tom?
It's a question for Tom. Tom, the breast cancer cohort, in the meta-analysis we published, it didn't really show that there was a difference across the breast cancer groups. It may be that there's just too many wide local excisions. It's not enough of an adrenergic inflammatory response. And I think that's one of the key drivers of this cancer pathway. There needs to be adrenergic inflammatory and then subsequent immune suppression that allows for micrometastatic disease to escape. Do you think it will show in a different cohort? Do you think we've chosen the right cohort, or do you think we're going to end up with a negative study as well?
I had the exact same concern myself when I saw the negative results of the study, given that, as you say, systemic inflammation and the stress response is likely to be proportional to the surgical insult, is breast surgery in itself relatively non-invasive, so to speak, and that we might see a beneficial effect of regional anesthesia on cancer recurrence in much larger, say, intra-abdominal surgeries. However, that question appears to have been answered by a very recent randomized controlled trial that's just been published in Anesthesiology this month, actually, again, led by Dan Sessler, predominantly, as far as I'm aware, in Chinese hospitals. It involved 1,800 patients undergoing major thoracic and abdominal surgeries. And again, it was found that epidural anesthesia use there had no effect on cancer recurrence. So that appears to have largely addressed that question.
Bernhard, you refer in your presentation to the fact that there are other, let's call them similar trials. You say Sweden, New York, China. I think I know about the Greater New York one, which I think is close to completion. What's different about your trial? Why not wait for those results?
It's a fair point, Monty. And the point of differentiation is the Lignocaine or the Lignocaine that we added to that study. The New York one is all abdominal cancer surgeries. The Swedish one was a cohort of breast and colon. And I'm not 100% sure, I can't remember, but I think it's major abdominal surgery as well. But adding in the Lignocaine component, I think, is a strong point of differentiation.
You mentioned Vijaya, a friend of ours, but also you used to work together. Bernhard, would you like to have the pleasure of introducing Vijaya for us?
Yeah, so Vijay, welcome. Vijay, I know back from MD Anderson Cancer days, and Vijay's traveled the world as well. Born in India, he's been the vice chair and acting chair at MD Anderson as well, and has been a phenomenal leader in this aspect. He's helped bring together a group of people who are interested in this work, and together we formed what was a collaborative group around onco-anesthesia, and he's been a key driver around that. I think there's a textbook that's coming out shortly on caring for the acute cancer patient. And so Vijay, powerhouse in this field, welcome.
Vijay, Dr. Gottumukkala, we said hello in the green room, so I'm not being exclusively rude to you by asking one of the other guests to introduce you. But as he highlighted that your colleagues working together, I thought we'd slip that one in. It's great to see you. How are you? You were saying that the weather's a bit unusual where you are at the moment.
Yeah, morning everybody. It's fantastic to be here participating in this panel. Yes, we've been having some strange weather patterns. In Houston, it's in the high 80s right now, while on the west coast, on Seattle and Portland, it's 118, 120. So I can't complain. I'm enjoying the weather right now, but I know what's to come.
So Vijay, another great pre-record. Thank you very much. I know many people actually watch the pre-records after the building the couch component of it. But I think you summarize things very, very nicely. The biology and the preclinical studies and the observational studies that drive these questions are absolutely tantalizing. But then you also throw in a few curveballs about polymorphisms, the fact that other factors may overwhelm these possible pharmacological effects. You conclude by saying, I think there's no level 1 evidence, so we should be confident with our equipoise. But you also throw in that there's no 2 patients and no 2 cancers. Is there an argument for going back to do some mechanistic studies as opposed to ploughing on with the massive non-filtered studies? Where do you stand on that?
Great point, Monty. As Bernhard had said, I've been at MD Anderson Cancer Centre for about 16 years now. I came from the University of Iowa to MD Anderson. Had the pleasure of working with Bernhard initially. We together have tried to come up with some risk scoring systems on cancer patients and how would they affect perioperative outcomes. Having worked here for 16 years and interacting with our oncology colleagues in medical oncology, surgical oncology, and radiation oncology, having the opportunity to better understand the cancer biology and its influence on outcomes, I've become a little more philosophical in my approach. And when you really look at the hierarchy of factors which influence cancer outcomes, in my opinion, cancer biology is the single most important factor. The second factor is patient factors. Obviously, Bernhard has touched on frailty and our ability to optimize the preoperative condition in certain patients. The third factor, which is the big X factor in all of this, is the surgeon skill. is your surgeon skilled enough to get a margin-free resection? And is he efficient and fast enough that you can do the procedure with minimal blood loss and avoiding blood transfusion? And then the fourth is the perioperative factor. So we are in a very exciting time in our field, in the perioperative medicine, that given the emerging demographics of aging population and rise in the cancer, it is incumbent and obligatory upon us to see what we can do, which is in our control, that we can influence cancer outcomes. The POET societies, the EBPOM, where you're focusing on the patient factors, goes very well, I think, together with what we are trying to understand and discuss today. So I think the gap or the big unknown is, why do all the preclinical translational work does not always translate into meaningful clinical outcomes, is again to do with the cancer biology. It's very important to see how do we follow these patients and what our primary end goal when we do a research design in perioperative care of the cancer patients. And Bernhard and I have worked together on the Valuebased trial, and we think event rate is critical because we know that breast cancer stage 2, the 5-year survival is 93%. So if you're going to follow your patients for less than 5 years, you're not able to collect any events pertaining to recurrence or cancer-specific survival. So while we design a research methodology, we have to be careful on the cancer staging, the cancer aggressiveness, the patient factors, and the appropriate, like you said, power and sample size and follow-up to make sure we're getting some meaningful outcome.
And with regards to the variation in practice in the background, Vijaya, and we'll extend this to everybody, and Slido will go to soon if people want to start asking questions from outside. Vijay, Professor Henrik Kellett, we often refer to as, one of the founders of the enhanced recovery principles. We know it was a global team effort. But he challenges us to say, unless you've got a fully embedded enhanced recovery program addressing all of the issues that we know are associated with accelerated recovery, you shouldn't really be asking randomized questions unless you're painting it on that canvas. Where are you in MD Anderson with regards to the enhanced recovery principles? And is it a fair challenge from him?
Absolutely. And, all of us know Henrik very well. I personally have invited Henrik 3 times over to MD Anderson about 10 years ago now, when I was starting enhanced recovery program at MD Anderson. Today we have one of the largest enhanced recovery programs for oncology care, I might say, in the world. We have 20 separate service lines in enhanced recovery, not just in surgical patients, but also in medical patients. We are doing enhanced recovery stem cell transplantation, enhanced recovery medical oncology. We are starting enhanced recovery in radiation oncology. And Joyce had said, and Bernhard had alluded to, fully understanding the cancer biology now, we know that the single most important factor which is going to influence recurrence-free survival is the patient's ability to go and pursue the adjuvant therapies that have been planned for them. So the only way we can make sure that happens is to minimize postoperative complications and making sure the patient gets back to a reasonable baseline status where they can comfortably tolerate the second hit, the adjuvant therapies in the immediate postoperative period. But I fully understand, agree, and support that we need to integrate everything related to the perioperative care and optimize functional recovery into our paradigm, and then see how that influences oncologic outcomes.
Because I would challenge the others, all of us, to address the fact that doing what we know currently would have a much more dramatic impact than the effect we're looking from some of these randomized interventions. I don't mean that as a kind of a downer on the efforts to address those fundamentally important questions. But if we look at the variation in length of stay that exists by just not doing what we know at the moment, could we please start with that one as a plea? Bernhard, am I being too grumpy here?
You spot on, Monty. Value-based healthcare is about reducing patient modifiable risk, and it's about reducing clinician variability. And if we can sort that out, that's value-based healthcare. That to me is enhanced recovery. It's modern surgical practice. No one would argue against you.
Joyce? Absolutely take on board what said that we should be doing what we already know to be working best for patient full-day recovery. But I would challenge that thought and say that if we don't answer the question with a randomized trial, then how do we know what to recommend as part of enhanced recovery for the future? So at the moment, we know that these are the important elements, but if we don't keep looking for answers, we don't know what to implement for the best outcome in the future.
Tom?
We may be looking in our trials at individual anesthetic agents or techniques versus one another and looking for an effect, but that effect may be quite small, whereas we may be doing the patient more good by trying to maximize the benefit we get by using the anesthetic techniques that has the best quality evidence behind them for addressing cancer recurrence, for instance, and Vapour-C will go some way to addressing that as well. And then combining that with whatever the evidence base is for minimizing patient complications, and as Vijay and Bernhard have said, getting them back to their intended oncological therapy as quickly as possible.
Vijay, I just want you to comment on the experience in COVID-19 of the sort of platform design. We seem to very rapidly, if you're looking from the outside, address some fundamentally important questions in the critical care of COVID-19 patients by sort of being a bit more liberal in how we randomize to different treatments and complex design. Why can't we just crack on and do that with these anesthetic type of questions in cancer?
As we're realizing that perioperative care is a bundled intervention, and as Tom had alluded to, if we get very specific into specific anesthetic drugs or techniques, I think we are losing the forest from the trees. So again, the challenge has always remained, and the debate continues, whether we should go the randomized controlled trial route or the pragmatic clinical trial design route. And Joyce and you, Monty, both of you are experts. And we're still not sure. To date, RCTs have been the gold standard. But in my humble opinion, I don't think RCTs translate very well to a clinical situation, although they give us some credence to put some evidence and give strong recommendations based on an RCT, but that does not really translate to clinical practice. So while we continue to understand those aspects of implementing and translating preclinical translational work to clinical outcomes and randomized controlled trials to what we need to advocate for effectiveness and efficacy in daily clinical practice, I think is still a challenge for all of us.
I think there's a little bit of doubt about, the time it takes to do the puristic randomized controlled trial and how we interpret the results. But I think you, like myself, are still fully in on the large RCT. I don't want to confuse anyone out there. I don't think we're suggesting don't do them. We're suggesting, I think, that there are parallel endeavours, because I think you're a key collaborator and indeed a principal investigator on many of the large RCTs.
Absolutely. Again, like we were discussing, I think the challenge for us is how do we bring that into clinical practice? And as Joyce had said, with an enhanced recovery program, it's a bundled intervention. Within that bundled intervention, I think we can argue which of those specific components may be better than the other, but we shouldn't forget the fact that perioperative care is a team sport. There is a lot more to be offered to beyond intraoperative care. And if I just may digress for just 1 second, I think particularly in the cancer patient population, and it applies to transplant population as well, I think the postoperative care plays a significant role in how these patients do. So when we are implementing postoperative care pathways, which most often our surgical colleagues take the responsibility, I think we'll also have to stratify them based on the patient's risk for postoperative complications. Not every patient's recovery trajectory is going to be the same, and all of us have seen this. Some patients who have a robotic low anterior resection go home second day, and some done by the same surgeon, by the same anesthesiologist, for the same patient factors, have a complication and a protracted recovery. So I think there is still a lot more for us to learn, but still, I think for any level 1 evidence, we still have to rely on an RCT.
Vijay, anything for Tom? And by default, Professor Donal Buggy, apart from congratulations for getting it over the line.
No, Donal has been instrumental in igniting this interest in me with that first paper in 2006. We have come a long way. Along the way, we have learned a lot. I think there's still a lot more to learn. And both Bernhard and Tom had alluded to perioperative inflammatory immune responses and how do we study that more and how do we bring in those 4 hierarchical factors I had discussed and how do we look at a broader scale, looking at patients' recovery, return to baseline, adjuvant therapies, and be very realistic on what the actual primary outcome of our studies are going to be and factor in those follow-up needs. So really excited for where we are right now and the opportunities to move ahead.
And for Joyce?
I think the Vitals is fantastic to look at patients' post-operative recovery from return to baseline and patient-centered care. But I think for specific oncological outcomes, as Bernhard has pointed out too, I think we'll have to follow up that post-operative surveillance for a much longer time and then stratify based on the disease stage, grade, and adjuvant therapies into looking at oncologic outcomes. But because of your robust database, I think there is a great potential there and really look forward to those results and working with you folks in the future.
You're collaborating, I think, on the trial that Bernhard was referring to. So do you have any open comments or questions related to that?
No, Bernhard and I have gone back and forth right from the very early stages of VAPOR-C, what interventions to include, what primary outcomes to look, and how to go about doing it. No trial is going to be a perfect trial, but we have to do the best we can, considering the logistics, the finances, the recruitment patterns. And the other thing we also have to bear in mind that surgical care and perioperative care is changing at a very rapid rate. So if you cannot complete a trial within 3 to 5 years from the start, the results are not going to be applicable by the time you get them published and the field has moved over. So I think all of those we have to bear in mind as we move forward and really excited to see where VAPOR-C takes us and to learn more.
So Bernhard, in your presentation, you refer to the fact that it's a global collaborative that is trying to deliver the trial. Could you expand on that for a moment so we can work out if we can try and join in within our geographies?
It is global in the sense that the funding that we have crosses borders, so there is a per-patient payment that can help centres. Our leading sites are Australian centres, but Australian population is relatively small. Hopefully we can rely and expand on our international partners. The US MD Anderson Cancer Centre, Dan Cecil at Cleveland Clinic are sort of lead sites for the US. University of Pittsburgh's coming on board. Wisconsin's coming on board. A number of other key centres are keen to be of assistance. PJ Devereaux in Canada is hoping to lead the Canadian sites for us. They're going to lead Ireland. Hopefully we'll get into the EU as well. And then in the UK, hopefully we'll collaborate and Imperial College will be the lead point there for us in the UK. But a lot of this is dependent on the risk appetite of the sponsor as well, and as well as getting international insurance in place, etc. So it's taking a little bit longer than we wanted to. COVID's really slowed down this process by at least 12 to 18 months, and so it is a big challenge for us. Can I just recognize the New Zealand team as well? I'd hate to leave someone out. They're actually doing a fantastic job down there as well.
Brilliant. The question from outside, I'll start with you, Vijay, because you definitely touched on this in your presentation. It's slightly loaded, this question. So what are the ways we can change the current culture now around using opioids for major surgery and include alternatives such as IV Lignocaine? So I think to my mind, there's two components to that. We're all trying to reduce opioid use. But if I may, there's a hint in this that suggests the fact that we know that IV Lignocaine is superior from the cancer perspective. So I'm going to ask you for two views on that.
Yeah, I think opioid sparing or reducing opioids, if we can effectively manage patient pain experience with alternate strategies, is a win-win situation. We will reduce opioid-related adverse events, we know, which is a fact, and that'll enhance patients' recovery trajectory, particularly with return of bowel function. So that's fantastic if we can do that well. With regards to IV lidocaine, again, just like the opioid story, there is very strong, compelling preclinical, in vivo, and translational work on the benefits of IV lidocaine in the cancer cell line population. But really, we still don't know whether that will translate to clinical benefit. And that's the reason why we wanted to include lidocaine as one of the arms in the 2x2 factorial of Valuebased. In my humble opinion, I think the jury is out there. There's definitely equipoise. I cannot with confidence say that we should use IV lidocaine to improve oncologic outcomes, although there may benefit. The question with IV lidocaine is also on the dose and duration of intervention. Are you going to stop it in the recovery area, or are you going to continue it for first 24 to 48 hours in the post-op period? And if so, what kind of safety mechanisms are you instituting in your setup to minimize the risk for cardiac complications? So I'm all into safety and efficacy and recovery and looking at the global picture. So based on everything we know right now, do opioid sparing if you can effectively do that, managing patients' pain experience. And if you can safely deliver IV lidocaine in your setup, whether it's in the intraoperative period or extending into immediate postoperative period, that's fine. We'll have to just wait and see if that will show any benefit for oncological.
Bernhard, one of my sort of tips for the youngsters doing exams is if we're doing a large, well-funded trial, we definitely don't know. So you can have a punt at the answer to something. There are very few things that we know. So equipoise with regards to lidocaine?
Equipoise all the way through, Monty. But I think we need to adapt our clinical practice and be dynamic with it. So it's like the enhanced recovery pathways. You know, in my clinical practice, I've adopted a TIVA strategy. I've adopted a lidocaine infusion because the science suggests that there is plausibility in this. But we have to do these big, large prospective randomized studies to prove that it's in fact true. But I don't think we should be static and still be delivering halothane for the rest of our lives.
Do you have an opinion on the use of dexamethasone intraop, used for POM-V from the cancer perspective? So I'm going to take that from the POM-V perspective, but the overall perspective as well. It's anti-inflammatory. It should have an effect on cancer recurrence.
Understanding cancer recurrence is important. How does it happen? I think you have circulating tumor cells that can get trapped in a microcapillary, which has been denuded by inflammatory response, etc., which can lead to that pre-metastatic niche. And I think dexamethasone, the anti-inflammatory component, as a single shot, has probably got an important role in looking after your microcirculation. And blocking that adrenergic inflammatory response is a key component. Dexamethasone should be useful inside that setting. Is chronic steroids good for you? Probably not. I think it's immune suppressant, etc. But I think a single dose, but we'll see what the PADDY study shows, if they do a sub-analysis or a secondary review. But essentially it didn't show any harm in the short-term outcome.
And that's a large steroid trial, correct?
Correct. It was, I think, nearly 8,000 patients randomized to 8 milligrams of dexamethasone with a primary outcome of wound infection.
Tom, closing comments.
With the publication of a couple of recent randomized controlled trials, we haven't been able to identify any beneficial effect of regional anesthesia on longer-term cancer outcomes. There are a number of trials that will be, the GA CARE study trial in the US should be published or should finish shortly. That will give us further information as to whether propofol TIVA versus volatile has any effect. And then Bernhard's Valuebased trial will probably give us best information that we can get on whether IV lidocaine, which is very under-researched and under-investigated in a clinical setting, has any effect on cancer recurrence. Beyond that, it's hard to know what will be the next thing to look at. Perhaps combining elements with potentially or based on laboratory evidence, potentially anti-cancer effects such as intravenous lidocaine plus propofol plus non-steroidals plus dexamethasone versus something else. But whether, if all of these trials come back with negative results, whether there's going to be any enthusiasm or appetite within the community for establishing these long, expensive and laborious trials, we'll just have to wait and see.
Now, Tom, we get told off for calling them negative results. They're clearly telling us that there's no difference. It's not.
Of course, yes.
We
No
have to
difference.
talk out the positive in that. Joyce, closing comments.
Picking up on what Tom said, even if we find no difference from these trials, at least when we had that conversation with the patient, we can make that decision together, balance the risk and benefits, and make the shared decision making much easier. So in many ways, I think all our trials will be very positive for patients and us.
Bernhard?
Monty, thank you. It's been a privilege. Keep the quality improvement initiatives going, reduce the variability in care, modify patients' risk beforehand, get them fit for surgery. Let's do the registry studies. Let's do the randomized control studies. That's the only way we're going to move this forward.
Vijay, closing comment.
Again, I'm just going to talk in terms of the profession and the clinician. So for the profession, it's a fantastic time to be in. We are understanding a lot more about cancer biology. We're getting involved, we are studying, we are researching, we are learning. But I think we have to become part of that multidisciplinary cancer care team, us anesthesiologists. For the individual clinician, right now, do everything you can to pre-optimize your patient and do your best to get your patient back on track to their baseline status, utilizing evidence-driven enhanced recovery principles. And we'll see where this takes us to improving the oncologic outcomes directly. This is the epidemiology. So each one of us will be facing cancer, unfortunately, in our own personal lives, one way or the other. And no matter what kind of practice you're in, you'll be taking care of cancer patients. So field is moving at a phenomenal pace. Keep at pace, keep reading, and all the very best with everything you do.
Thanks very much, team. Thanks very much, everyone. We're going to take a break.
Thank you.
We'll see you back soon.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.